Muy buenos días a todos. Bienvenidos a este webinar número 81 de la Federación Nacional de Neonatología de México. A nombre del Dr. Moisés Quiles, presidente de la Federación, les damos la más cordial bienvenida. Soy el Dr. Dylan Izaguirre, neonatólogo intensivista adscrito a la UCIN del INPER, y agradezco la oportunidad de coordinar esta sesión al Dr. Moisés y al Dr. Encalada por la invitación. Es un gran honor para mí presentar al Dr. Satyan, quien es para muchos de nosotros considerado un gran neonatólogo. Es jefe de la División de Pediatría del Davis Children's Hospital en California. El doctor es conocido por tener amplia experiencia clínica y de investigación en trastornos de la transición neonatal como asfixia e hipertensión pulmonar persistente del recién nacido. A la fecha ha publicado casi 200 artículos originales, 50 artículos de revisión y participado en 15 capítulos de libros. Y además es el editor del conocido libro Essentials of Neonatal Ventilation. Además de que sus ilustraciones médicas ya son un referente en la neonatología por lo muy bien diseñadas y explicadas que son. El día de hoy nos presentará un tema de gran relevancia, el cual es titulado ¿Qué puede enseñarnos el feto sobre el manejo de hipertensión pulmonar persistente del recién nacido? Le doy la más cordial bienvenida y cedo la palabra al Dr. Satyan. Welcome, Dr. Satyan. We really appreciate your time to be here with us. Go ahead. Thanks.
Thank you, Dr. Dylan. Thank you for the kind introduction. Let me share my screen. Can you see my slides?
Yes, doctor.
Okay, perfect. Thank you. Again, thank you for the introduction and thank you for joining. Today, I'll be talking about management of PPHN. What can the fetus teach us? The objectives for today's talk include ventilation strategies in use of surfactant delivery, pulmonary vasodilator therapy in neonatal hypoxic respiratory failure, early recognition of pulmonary hypertension and hypoxemic respiratory failure, and optimal management of pulmonary hypertension in term infants. I will talk from the perspective of what a fetus would do to treat pulmonary hypertension. And I will use an example of a patient with congenital diaphragmatic hernia throughout this talk. So if you think of a fetus, the fetus is in a state of pulmonary hypertension. So if we assume on this figure that the vertical axis is vascular resistance or pulmonary arterial pressure, then in a fetus, the pressure in the lungs is very high and the pressure in the placenta is very low. Always, blood flows from an area of high resistance towards the area of low resistance. And for this reason, in a fetus, there is very little blood going to the lungs and a lot of blood is going to the placenta. The fetus survives such high pulmonary blood pressures because of a combination of high fetal hemoglobin, ductal patency, which maintains low afterload, high blood flow, and it tolerates hypoxemia. So what does this mean? So if you think of the left ventricle is pumping to the placenta, which has low pressures. On the other hand, the right ventricle is also pumping towards the placenta through the ductus arteriosus and not really pumping much blood to the lung. So for this reason, both the right ventricle and the left ventricle face less stress in a fetus. Next, a fetus has high fetal hemoglobin and has high cardiac output, and these can maintain oxygen delivery despite low PaO2. So the net effect of this is that the baby's heart is happy. It doesn't worry about PO2, but has less cardiac stress. And if you have a heart that has less cardiac stress, the baby does well. Once the baby is born, if everything is going well, then the lungs start ventilating and the pulmonary vascular resistance decreases and placenta is removed and the umbilical arteries are clamped off. This results in high blood pressure in the systemic circulation and low blood pressure in the pulmonary circulation, resulting in blood going towards the lung, establishing the lungs as the site of gas exchange. On the other hand, if things don't go well, and if the baby is sick with pulmonary hypertension, in PPHN circulation, the lungs still have high blood pressure and the pulmonary vascular resistance is high. And for this reason, there is right to left shunting across the ductus arteriosus and right to left shunting across the foramen ovale, resulting in cyanosis and a sick baby. Initially, the ductus is open, but subsequently the ductus will close. And this closure of the ductus results in the right ventricular afterload going up. So the right ventricle gradually hypertrophies and starts developing right ventricular failure. This kind of stress, increased ventricular afterload and stress, can lead to ventricular failure. And when the heart is not happy, these babies don't do well. So closely monitoring the heart is really important while managing babies with persistent pulmonary hypertension of the newborn. So if you have a baby who has evidence of congenital diaphragmatic hernia, there are a few things that you need to watch for when you go to the delivery room. Has there been an ultrasound before birth? Has anybody evaluated the size of the lungs before birth? Because if the baby has small lung size, as determined by percentage predicted lung volume, if this lung volume is low, then there's a high risk of these babies dying. On the other hand, if the lung volume is high, there's a higher chance of survival in these babies. Other factors that determine prognosis in diaphragmatic hernia include severe respiratory failure, low PaO2 and high PaCO2 in these babies, presence of cardiac dysfunction, especially ventricular dysfunction, and presence of liver in the chest and associated anomalies. These factors determine if this baby is going to do well or not. When you think of congenital diaphragmatic hernia, many of you are familiar with an X-ray like this. There is intestinal tissue, intestines in the thorax that displaces the heart and the mediastinum to the opposite side, resulting in a small size of the lung, pulmonary hypoplasia, both on the ipsilateral side and the contralateral side. This results in significant bilateral pulmonary hypoplasia. The three features of congenital diaphragmatic hernia include pulmonary hypoplasia, cardiac dysfunction, and pulmonary hypertension. All these three contribute to pathophysiology of congenital diaphragmatic hernia. But each of these manifestations present in a different manner, and I will go through those in the next slides. If you think of pulmonary hypoplasia, the main manifestation here is with a high PCO2 level. If you think of pulmonary hypertension, the chief manifestation here is low PaO2 level. And if you think of cardiac dysfunction, the chief manifestation here is acidosis with a low pH and hypoperfusion. So how do you correct these anomalies? For the treatment of pulmonary hypertension, you use inhaled nitric oxide or ECMO if needed. To treat hypoperfusion and cardiac dysfunction, you will use milrinone, epinephrine, hydrocortisone, or sometimes veno-arterial ECMO. But if you have significant pulmonary hypoplasia, then sometimes early repair is suggested. And one of the forms of early repair being done is what is called as fetal intervention. So when a pregnant mother comes to you with a baby with diaphragmatic hernia, there are a few things that need to be evaluated. What is the gestational age of this baby? Are there any associated anomalies? What is the lung volume? And is the liver up in the thorax or down in the abdomen? So these are the four things you need to look into. Especially associated anomalies, cardiac anomalies really contribute to the prognosis here. One common number that's commonly evaluated is what is called as lung to head ratio or LHR. This LHR is measured by checking the contralateral lung diameters. You measure the length of the lung, the breadth of the lung, and figure out the lung area. Then this is done at the level of the 4-chamber view of the heart. Subsequently, you measure the circumference of the head to measure the head circumference. And then you calculate the lung to head ratio by estimating the lung area and dividing by the head circumference. So this lung to head ratio, if it's less than 25% of what is expected, then the baby has a poor outcome with the left-sided hernia. And if it's less than 45% for a right-sided hernia, then also there is poor outcome. So this number is really important. Observe to expected lung to head ratio of less than 25%. So as you may have heard, Jan Deprest and his colleagues recently did fetal intervention to evaluate the management of babies with diaphragmatic hernia. What they did was they took babies with either moderate hyperplasia or severe hyperplasia with diaphragmatic hernia, and then they did fetal intervention at either 30 weeks of gestation or at 27 weeks of gestation. The intervention included insertion of a tube into the baby's trachea and occluding the trachea using a balloon. When this trachea is occluded by a balloon, then there is accumulation of lung liquid in the lungs, resulting in increase in lung size, and this results in improvement of pulmonary hyperplasia. So they compared 40 babies with severe diaphragmatic hernia with 40 babies with either intervention or with expectant care. As you can see here, survival to NICU discharge was much better in infants that had a fetal intervention with tracheal occlusion compared to those that did not have tracheal occlusion, 40% versus 15%. The need for ECMO was significantly lower following Feto, and survival to 6 months was also much better in these babies. And survival to 6 months without oxygen supplementation was also better. So in the future, it is possible that more and more centers will resort to tracheal occlusion in babies with diaphragmatic hernia during the fetal period. So in the subsequent slides, I will ask you a few questions, and all questions have choices A, B, C, and D. And what I would like you to do is put your answer in the chat. So this baby has an MRI done, and baby has really low lung volumes. The stomach, the left liver are all up in the thorax, resulting in severe mediastinal shift. The neonatal and obstetric team discuss cord management plans for this delivery. Baby appears dusky at birth, but has a good cry and is vigorous. And the umbilical arterial cord gas is 736, 43 PCO2, 17 PO2, and -1 base excess. What is the optimal cord management for this infant? Would you do immediate cord clamping and resuscitation? Or B, delayed cord clamping for 60 seconds? C, intact cord milking, stripping the cord 4 times? Or cut cord milking? You cut the cord and then milk the cord. Which of these would you prefer? Kindly put your answer in the chat. Great. Most of you are choosing B. A few people are choosing D. Great, awesome. So in my opinion, the optimal management of these babies should include delayed cord clamping. So let's briefly talk about delivery room management of babies with diaphragmatic hernia. One thing you should consider is delayed cord clamping, because that will contribute to more hemoglobin to the baby and increase hemoglobin levels and oxygen carrying capacity in the baby. The second, since babies have a diaphragmatic hernia, you should avoid bag mask ventilation. Subsequently, because you do not want to blow air into the lungs. Subsequently, tolerate preductal SpO2 between 85 and 95%. Avoid high peak inflation pressures of more than 25 centimeters of water, and try using low PEEP, because high pressures can damage these small lungs. Intubate if needed, and when you intubate, normally we use a formula 6 plus weight in kg, but babies with diaphragmatic hernia tend to have a shorter trachea And for this reason, it's better to use a formula of 5.5 plus weight in kg when the baby has a diaphragmatic hernia. Use orogastric tube, put a tube into the baby's stomach and connect it to suction so that you suck all the air out of the stomach. So that brings us to the next question. The respiratory therapist is setting up the TP's resuscitator and wants to know the initial inspired oxygen concentration for the infant. A prenatal pulse oximeter is being set up. The optimal initial inspired oxygen concentration for this infant is A, 100%, B, 50%, C, 30%, and D, 21%. Please answer in the chat. I'll give you a minute to complete answers. Lots of variation here. Most of you chose D. Some of you are choosing C. Okay, that's great. There is no correct answer to this question, but I personally choose somewhere between 50% to or lower. And let's talk about that in a second. So the babies with diaphragmatic hernia tend to have very high pulmonary arterial pressure. And for that reason, you can choose either 21%, but usually that's fairly low. So typically most centers start off with 50% oxygen for babies with diaphragmatic hernia and then monitor prerectal oxygen saturation. So if you chose 21% or 30% or 50%, all of those answers are correct. You really do not need 100% oxygen. So 100% oxygen is not the right answer. So once you start this oxygen, here is a paper from Children's Hospital of Philadelphia, where they have shown that if you start oxygen at 50% and then monitor the baby's heart rate, if the baby's heart rate is above 100 after 30 seconds of ventilation, then you do not need any more intervention. You can continue oxygen at 50%. And assess preductal pulse ox at 5 minutes of age. If the pulse ox is more than 80, then you are fine. If the pulse ox is less than 80, then increase the oxygen by 10% every 30 seconds. On the other hand, if the baby is bradycardic and the heart rate is below 100 after 30 seconds of ventilation, it may be important for you to increase the oxygen to 100% to make sure that the baby does not suffer any consequences. Titrate and maintain the FiO2 to maintain prerectal oxygen saturations between 85 and 95%. So make sure you put a pulse ox and put the pulse ox on the right hand and follow oxygen titration. It's really important to monitor these saturations and maintain between 85 and 95%. If a baby continues in 50% oxygen and does not need an increase in FiO2 to 100%, this baby's mortality is 5.1% if the baby stays in 50% oxygen. On the other hand, if the baby requires 100% oxygen in the delivery room, the mortality goes up to 31%. And that's a clear indication that this baby has significant lung disease or pulmonary hyperplasia. Okay, here is the baby's X-ray after birth. Birth weight is 3096 grams, intubated with a 3.5 endotracheal tube at 8.5 centimeters. PIP is 20, PP is 4, baby is requiring 35% oxygen. He's on a tidal volume of 4 ml per kg. And here is the blood gas. PO2 90, PCO2 37, pH 7.37, excuse me, bicarb 21, and base excess is -4. So here is the blood gas of this baby. And here is the X-ray. So you got one more X-ray, and it is how the lungs look. So now that you have this gas with a PCO2 of 37 on 35% oxygen, the preductal sats are 99% and postductal sats are 95%. What would you do next to this baby? Baby is on a PEEP of 4. Would you reduce the PEEP to 3? Would you switch to a high frequency oscillator? Would you reduce tidal volume to 3.5 ml per kg, or you decrease FiO2? What would you do? So most of you are choosing D. Great. So this saturation of 99% is too high. You need to reduce the FiO2 down to bring this sats down to around 95%. The other thing to consider is that this CO2 of 37 is also low. For those of you who chose to decrease the tidal volume to 3.5, that's also not a bad approach. And I will also talk about PEEP in a second. So the right thing to do immediately in this baby is to reduce the FiO2 to bring the sats, preductal sats, to 95% or less. So in the past, when we managed babies with diaphragmatic hernia, our goal was to beat up the lung and get rid of all the CO2 and try to maintain very high oxygen levels. So this old practice of trying to maintain babies with an extremely alkalotic pH, extreme hypocarbia with low CO2, very high PO2, and extreme base excess by giving sodium bicarbonate infusion. All of these practices are wrong, and we no longer practice them anymore. The current approach is what is called as gentle ventilation, promoted by Dr. Jen Wang from Columbia University in New York City. And he suggests gentle ventilation using tolerable hypoxemia, maintain PaO to 80 millimeters of mercury, or pulse ox between 85 and 95%, and permissive hypercapnia, maintain CO2 between 50 and 60, as long as the pH is above 7.5, and minimize cardiac stress. So this is the right approach to managing babies with diaphragmatic hernia. Saturations between 85 and 95%, and PCO2 in the 50s. So the key to remember is that just like a fetus, where the oxygenation of the brain and the lung is more important, and for this reason, maintaining a preductal oxygen saturation of 85 to 95% is really crucial. Even if the postductal saturation is more than 70, that's adequate, as long as the baby has normal lactate and has a normal urine output. If the baby's lactate is going higher and higher, that's not a good sign, and then you need higher oxygen levels. Or if the baby does not have good urine output, that's also not a good sign, in which case you need higher oxygen levels. But if the lactate is normal and the urine output is adequate in babies with diaphragmatic hernia, it's okay to tolerate a preductal oxygen saturation between 85 and 95%. So that brings us to the next question. Here is the baby's X-ray. You see a big diaphragmatic hernia here. Here is the orogastric tube on section. Here's an umbilical arterial line and an umbilical venous line, a PIC line. And the baby's oxygen was weaned down to 21%. Remember, most of you chose D, so the oxygen was turned down to 21%. The tidal volume was decreased to 3.5 ml per kg, and the PEEP is -3. Now the baby has a preductal SpO2 of 91% and a postductal SpO2 of 77%. And here is the blood gas from the umbilical arterial line. pH 7.41, PCO2 41, PO2 32, and base excess is +1. And the oxygenation index is 7. What is the next step in this baby's management? A, no change in settings. B, increased inspired oxygen concentration. Start inhaled nitric oxide. Check lactic acid and urine output. What's the right answer? Please choose an answer. Great. The right answer here is D, because remember I told you in the previous slide, you need to check lactate level and make sure the lactate level is normal. You need to also check the urine output and make sure that's normal. So the first step that you do here is to check the lactic acid and urine output. And if those numbers are normal, then you sit tight and don't have to do any change, because the saturation is 91% in the preductal region. But if the lactic acid is high, then you may have to increase oxygen concentrations. So the right answer to this question is D. So when you manage patients with diaphragmatic hernia, often many of these patients go through what is called as a honeymoon period. where babies tend to do well for the first few hours of life. So these babies are born with high fetal pulmonary vascular resistance. And when they are born, there's a decrease in pulmonary vascular resistance. But subsequently, babies with diaphragmatic hernia tend to have some degree of left ventricular hyperplasia and dysfunction, and that in turn leads to pulmonary venous hypertension. So in these instances, the use of milrinone may be important to improve left ventricular function and prevent pulmonary venous hypertension. And milrinone can also limit pulmonary arterial hypertension as it is a pulmonary vasodilator. The next issue in babies with diaphragmatic hernia is that with increased ventilation and oxygen toxicity, babies tend to get worse. And practicing gentle ventilation and using pulmonary vasodilator therapy can ameliorate and reduce the risk of pulmonary hypertension in these infants. So it's really important to also consider maintaining ductal patency. If there's a lot of stress on the right ventricle, it's important to maintain the ductus open by using intravenous prostaglandins. So the therapy for pulmonary hypertension in diaphragmatic hernia includes the use of milrinone, other pulmonary vasodilators, gentle ventilation, and maintaining ductal patency using PGE1. So continuing with this baby, remember the last time you wanted to check this baby's lactate level. So the infant is stable on current vent settings, but the split between preductal and postductal SpO2 has widened. So the preductal oxygenation is 92%, the leg oxygenation is 74%, and the baby is on 30% oxygen. Here is the blood gas: pH 723, PCO2 59, PO2 33, the saturation range is 73%, and the base deficit is -5. And you measured lactic acid, and the lactic acid numbers are high, 5.5. An echocardiogram is done on the baby, and the baby echo shows flat interventricular septum, tricuspid regurgitation jet with an RV pressure of 59 millimeters of mercury, dilation of the right ventricle, dilation of the right atrium, bidirectional shunt of the PDA and the PFO, and a narrow transverse arch. So here is the X-ray on this baby. Okay, the PO2 is 33, and the lactic acid is going up to 5.5. So they have a high lactic acid level. So what is the most appropriate next step in management? Increased inspired oxygen, start PGE1 infusion, inhale nitric oxide, switch to high frequency oscillator, or do immediate surgery to reduce diaphragmatic hernia. So you have 5 choices, A, B, C, D, E. Kindly put your answer in the chat button. D, B, C, D, O, lots of variation in answers now. Okay. Most of you are choosing between A and D. Okay. So the ideal step here is A. You increase oxygen concentration first. Immediate surgery is not the answer here. The baby is in pulmonary hypertension, and doing surgery now will only make things worse. So the proper answer here is increase the inspired oxygen concentration, because remember, in this baby, you are seeing a high lactate. If the lactate is going up, you need to help the baby by increasing oxygen. So increase the inspired oxygen concentration. And if that does not work, then you can go to other therapies. So why is it important to maintain oxygen levels in these babies? Here is a graph from Professor A. Brudolf, where he plotted PO2 values along the horizontal axis here and pulmonary vascular resistance along the vertical axis here. And what he showed was that when the PaO2 levels fall below 45 millimeters of mercury, you may see an increase in pulmonary vascular resistance. And he showed that hypoxia, having very low PO2 values, causes pulmonary vasoconstriction, but normoxia, maintaining values between 50 and 80 millimeters of mercury, causes pulmonary vasodilation, but hyperoxia, maintaining PO2 values above 100 millimeters of mercury, does not cause any additional pulmonary vasodilation, but in fact can cause toxicity. It's also important to remember that pulmonary vascular resistance is maintained by this precapillary pulmonary arteriole. If you think this is the heart, here is the alveolus, here is the pulmonary artery, and here is the pulmonary vein. This oxygen tension surrounding the precapillary pulmonary arteriole is what determines pulmonary vascular resistance. So this is determined by a combination of the alveolar oxygen concentration, which in turn determines pulmonary venous PO2 and preductal PO2. And this is the reason why preductal PO2 is really important to assess pulmonary vascular resistance. The other factor that's important here is the pulmonary arterial PO2 level, which is also contributing to oxygen tension here. So maintaining adequate oxygen concentrations in the alveolus is really important to keep the precapillary pulmonary arteriole pressure low. So if you have a baby with diaphragmatic hernia, whose pulse ox is 85% preductally and postductally 70% and is on 30% oxygen, do you increase the inspired oxygen concentration to 50% to achieve a better preductal oxygen concentration? This answer really depends on what the baby's lactate level is. So you have to check a serum lactate in these patients. So here is a study done by Rawat and colleagues where they looked at arterial pulse oximetry between 86 to 91%, or 90 to 94%, 93 to 97%, and 96 to 100%. And they looked at various parameters. Saturations below 90% caused high pulmonary vascular resistance. So that was not good. Having saturations very high in the 100% range also increased pulmonary vascular resistance, and that was not good either. So maintaining saturations in this range is probably ideal, but in this particular instance, because although the PO2 levels were very similar between the two cases, babies required slightly higher oxygen levels while maintaining saturations in the 93 to 97%. And for that reason, they noticed a significant reduction in pulmonary vascular resistance. So it's important to maintain oxygen saturations in this range between 90 and 97, preferably in the mid-90s when the lactate levels are going up in babies with pulmonary hypertension. The next question is as to whether we should use an oscillator or a conventional ventilator while managing babies with diaphragmatic hernia. And the answer to this question comes from a trial called as the Vichy trial that was done in Europe. And what they showed here was that if you choose high-frequency oscillator for initial therapy, then the incidence of ECMO was significantly higher, use of inhaled nitric oxide was higher, use of sildenafil and duration of inotropic therapy was higher in these instances. So this goes to show that conventional ventilation is as good, if not better, than routine high-frequency oscillatory ventilation. So most of us prefer using conventional ventilation while managing babies with diaphragmatic hernia. Only if the PaCO2 is above 65 millimeters of mercury, despite conventional ventilation of more than 60 per minute rate, then you can consider using an oscillator in these instances. The next therapy that's really important is the use of PGE1. So if you have a baby who has significant pulmonary hypertension, resulting in right to left shunt across the PFO, right ventricular dilation and dysfunction, and very high afterload due to increased pulmonary vascular resistance, but the ductus is closing, this will result in reduced right ventricular function. So in these instances, using an agent such as IV milrinone will enhance the function of the ventricle, and using an agent such as IV PGE1 will open up the ductus, resulting in reduced strain on the right ventricle. So a combination of milrinone and IV PGE1 is important while managing patients with diaphragmatic hernia who have right ventricular dysfunction and with a closing ductus. One other medication not in diaphragmatic hernia, this slide does not apply to diaphragmatic hernia, but if you have a patient who has significant lung disease, like respiratory distress syndrome or meconium aspiration syndrome or pneumonia, In these patients, using surfactant might be beneficial as well. Here is a randomized trial by Gonzalez and colleagues from Chile, published in the Journal of Perinatology in 2020, where they took patients with pulmonary hypertension and randomized them to either receive inhaled nitric oxide or a combination of surfactant and inhaled nitric oxide. Again, this is not diaphragmatic hernia. This is a patient with meconium aspiration syndrome or RDS or pneumonia. So what they observed was that babies that got surfactant and nitric oxide tended to do better with lower oxygenation index compared to babies that only got nitric oxide. So why does this happen? If you think of this, assume that here is the lung, here is a collapsed alveolus, and here is an over-distended alveolus. The collapsed alveolus next to the blood vessels next to the collapsed alveolus have hypoxic pulmonary vasoconstriction. The blood vessels next to an over-distended alveolus tend to are compressed because of the distension, resulting in increased pulmonary vascular resistance. In this baby, if you go ahead and give inhaled nitric oxide will not enter this collapsed alveolus. It will enter the over-distended alveolus, but since the vessels are already compressed, there will not be a much reduction in pulmonary vascular resistance. On the other hand, if you give surfactant first and recruit both the lungs and then give inhaled nitric oxide, you will see optimal lung distension, resulting in pulmonary vasodilation and decreased pulmonary vascular resistance. So as shown in this slide, the use of surfactant is beneficial in babies, but remember, this study excluded all patients with diaphragmatic hernia. So again, to illustrate the same fact, if you have a diseased lung, nitric oxide only goes to the areas of the lung that are not diseased, and recruiting the lung properly using surfactant is really important so that when the lung is well recruited, nitric oxide is much more effective in its effect. So here is an X-ray that was given to me by Dr. Vikram Dumpa, who showed that in babies who have significant lung disease like this, giving them surfactant and recruiting the lung will result in a much better lung aeration and resulting in reduction in pulmonary vascular resistance. So intratracheal surfactant is indicated in babies with pulmonary hypertension secondary to parenchymal lung disease when the oxygenation index is more than 5 and the need for more than 40% oxygen to maintain a prenatal SAT of more than 90%. The dose is a standard dose, but in babies with diaphragmatic hernia or idiopathic black lung PPHN, you should not use surfactant. It's a contraindication to use surfactant in diaphragmatic hernia. What other things can you do with diaphragmatic hernia? One thing to remember is to choose tidal volumes approximately 4 ml per kg because the lungs are small, but there is some degree of tracheal ballooning in babies with diaphragmatic hernia. So the trachea can balloon with each respiration, and this will result in loss of some tidal volume in the upper trachea. And for this reason, it's probably prudent to use a decent tidal volume as 4 ml per kg in this patient. The other thing that affects prognosis is to how big the defect is. See the baby here who has a huge defect in the diaphragm, and the hole is really big in the diaphragm. And if you need to place a big patch to close the diaphragmatic hole, these babies do not do well either. So the use of a patch and the presence of a large hole in the diaphragm is associated with poor prognosis in babies with diaphragmatic hernia. Okay, let's move on to the next question. So this baby underwent surgery. See, all the hernia is gone. It has been repaired and pulled down. Post-operatively, after surgery, infant had to be placed on high-frequency oscillatory ventilator with 70% oxygen requirement. The ABG is 731, 61, 33, and +4. Blood pressure is 74 by 30 millimeters of mercury. Echocardiogram shows flat interventricular septum, low LV ejection fraction, right to left shunt at the PDA, but left to right shunt at the PFO. So the PDA is right to left, the PFO is left to right, and the baby has low left ventricular ejection fraction. What is the next step in this infant's management? A, initiate inhaled nitric oxide at 20 parts per million, switch back to conventional ventilator, start milrinone infusion, reduce frequency on the oscillator to target a PaCO2 of 25 millimeters of mercury, and a pH of 755. Which of these is your choice? A, B, C, or D? A or C, says Carlos. Most of you are choosing C. Okay, awesome. So when you have a baby with low left ventricular ejection fraction and left ventricular dysfunction, the drug of choice is milrinone. So the answer here is C. So if you give inhaled nitric oxide to these babies get really worse. And the reason is as follows. So when you have a baby with left ventricular dysfunction, because the LV is not working well, there is elevated left atrial pressure. And this elevated left atrial pressure will cause a left to right shunt across the oval foramen. On the other hand, because of pulmonary hypertension, these babies have a right to left shunt across the ductus arteriosus. So when you have elevated left atrial pressure, there is associated pulmonary venous hypertension. And when these babies get inhaled nitric oxide, then the lung gets flooded because there is no place for the blood to go out. So this is like having a toilet where there is a block in the toilet due to left ventricular dysfunction. And if you keep on flushing this toilet without fixing the dysfunction, then you will create a mess. On the other hand, the right treatment for this condition is the use of the drug milrinone, it's just like using a plunger to remove the block. And once the block is removed, once the left ventricular function gets better, then you'll be able to flush and use inhaled nitric oxide. So if you have left ventricular dysfunction, start milrinone first, improve the function of the left ventricle, and then after the LV function is better, consider using inhaled nitric oxide. So this is a study where they compared patients who had an ejection fraction of less than 55 or left ventricular dysfunction and compared them with patients who had normal ejection fractions. As you can see in this slide, the use of ECMO was much higher when you have left ventricular dysfunction, 42% compared to 15.6% when the ejection fraction is better. Similarly, when you look at patients who respond to nitric oxide and compare them to patients who do not respond to nitric oxide, patients who do not respond to nitric oxide have a higher incidence of LV dysfunction compared to patients who respond to nitric oxide. So this goes to show that the presence of left ventricular dysfunction and poor response to inhaled nitric oxide is often associated with the increased need for ECMO, and these babies do not do well. Okay, what about systemic blood pressure? So here is this baby now has right ventricular hypertrophy and the systolic tricuspid regurgitation jet, and the pressure in the right ventricle is 90 millimeters of mercury. So you measure the baby's blood pressure, and the systemic blood pressure is 64 millimeters of mercury systolic. So there is a huge elevation in the right ventricular pressure and fairly low left ventricular pressure. So now that this baby has a right to left shunt across the PFO and a right to left shunt across the PDA, what's the important next step in the management? A, give a fluid bolus to this baby, start dopamine at 10 to 15 mics per kg to increase the systolic blood pressure here to more than 90, increase the dose of nitric oxide from 20 parts to 80 parts per million, start the baby on IV sildenafil. Which of these is your answer? Please go ahead and put it in the chat. So let's see. Emma wants to do B, which is dopamine. Zonia wants to do C, which is inhaled nitric oxide. Beatrice wants to do D. Maribel wants to do D as well. Martha wants to do D. Okay. So more and more of you are choosing D here. Giving a fluid bolus is not a good idea at this time because the right atrial pressure is already high. So giving a fluid bolus will further increase central vascular resistance. So A is wrong. B, dopamine is not selective. And I will talk about this in a second. So using dopamine is not the right answer either. So use of inhaled nitric oxide going from 20 parts to 80 parts results in less improvement. So C is probably not the right answer. And the right answer here is consider using IV sildenafil load, because you really want to bring down this number or reduce this pressure. So why is the use of dopamine the wrong answer? Typically, what we would like to do by using dopamine is if the RV pressure is 90 and the LV pressure is 64, you want to use dopamine to increase the LV pressure to 94 so that the shunt at the PFO level and the shunt at the PDA level stop. But this doesn't happen this way when you use dopamine. Dopamine is not selective to systemic circulation. So when you put a baby on dopamine, here is the increase in systemic arterial pressure in babies with PPHN. Here is the increase in pulmonary arterial pressure with babies with PPHN. So when you use a dose of more than 10 mics per kg per minute of dopamine, you will see an increase in pulmonary arterial pressure also. So the pressure not only goes up on the left side, there's an increase in pressure on the right side too when you use dopamine. So dopamine is not selective, and so high doses of dopamine, about 10 mics per kg per minute, should not be used in babies with PPHN to elevate the blood pressure if that systemic blood pressure is already normal. So achieving suprasystemic levels of blood pressure is not a good idea. So if you think of it from the perspective of the right ventricle, the important thing in management of PPHN is to keep the heart happy. So to keep the heart happy, if you keep the pressure in the right ventricle low, and the right ventricle the pressure is being kept low by two pop-offs. One pop-off is at the PFO, the second pop-off is at the PDA. So this is like having a pressure cooker, which is under very high pressure. So when this pop-off valve here, where the steam is being released, is similar to what you see with the PDA and the PFO. If you use high-dose dopamine and close this off and don't let the right ventricle decompress, then that can result in severe right ventricular failure and the baby will crash. So this is not to be done. So don't stress the heart. Even if the baby is slightly hypoxemic, that's okay. Do not excessively increase the afterload by using high doses of dopamine in babies with pulmonary hypertension. The next thing to consider is that if a baby has simultaneous evidence of left ventricular hyperplasia, in these patients, it may be prudent to use a drug such as Vasopressin, because Vasopressin is a selective systemic vasoconstrictor and might help in babies with diaphragmatic hernia, as this paper from Denver. But when you use Vasopressin, you should be very careful about maintaining urine output and avoiding hyponatremia, because when you use Vasopressin, you will see a huge drop in urine output and the serum sodium levels decrease. So watch for hyponatremia and oliguria. So to conclude this talk, CDH or diaphragmatic hernia is characterized by pulmonary hyperplasia, pulmonary hypertension, and right and left ventricular dysfunction. To manage pulmonary hyperplasia, consider using gentle lung protective ventilation, SpO2 targets in the low 90s, and permissive hypercapnia. And if this fails, consider high frequency ventilation if conventional ventilation fails. For pulmonary hypertension, consider the use of pulmonary vasodilators, inhaled nitric oxide, sildenafil, bosentan, or prostaglandins, and correction of systemic hypotension. When there is ventricular dysfunction, consider the use of inodilators such as milrinone. And when there is ductal patency when the ductus is starting to close, consider using PGE1 for pop-off. So a good management of diaphragmatic hernia includes the use of pulmonary vasodilators, IV PGE1, and milrinone to enhance the function of the heart. With that, I will stop. If you have any questions, feel free to ask your questions or email me at slakshmi@ucdavis.edu. Here is my WhatsApp phone number, and here is my Twitter. If you want to tweet and reach out to me, I'm happy to get back to you. I sincerely thank you for this opportunity and attention, and I'm happy to take questions. Thank you for your comments. And I really appreciate you actively participating with responses to these questions.
Muchas gracias, doctor, por su excelente presentación. Thank you, doctor, for your excellent presentation.
Thank you, Dr. Gillen.
For questions.
Okay.
There are many thanks to your presentation in the comment section. The first one says, what do you think about the use of high frequency ventilation plus volume guaranteeing congenital diaphragmatic hernia as a protective pulmonary strategy?
Okay. So I did not show you a few slides, but I personally prefer to use conventional ventilation using volume guarantee mode with low PEEPs. I use a PEEP of 3 and try to maintain the pressure really low, because the problem in diaphragmatic hernia is that the lungs are really small and over-distending the lungs causes more problems. So I tend to keep the PEEP low, use a volume guarantee of 4 ml per kg, a PEEP of 3, and then manage these patients, and that seems to work well. If it fails, if the baby has a CO2 of more than 65, despite a rate of 60 on conventional ventilation, then I switch the baby over to a high frequency ventilator. I do not personally choose high frequency as the first choice.
Thank you, doctor. Other question says, what do you think about the use of levosimendan in cases with serious ventricular dysfunction?
Okay. Levosimendan is a fairly effective drug, but there is very limited data in the use in babies. And in the US, we don't have approval from the FDA for its use in infants. So we commonly do not use it, and we prefer to use milrinone. If milrinone does not work, then one might consider levosimendan, but I personally don't use it. I try using milrinone at high doses.
Okay, thank you. And the other says, it's better to use your diuretic. And what diuretic is your best option?
For a short, I tend not to use many diuretics in babies with pulmonary hypertension, because one of the issues with using diuretics is that it tends to reduce your volume and sometimes drop the blood pressure, and babies do not tolerate it well. But once pulmonary hypertension is controlled, especially if the baby has edema, I tend to use 1 dose of Lasix, and if that does not work, follow subsequently with diural or aldactone for long-term use. So I tend to minimize use of diuretics when the baby is acutely sick with pulmonary hypertension, because of the worry about hypovolemia and low blood pressure.
Perfect. Another question is, what postnatal day or when is the appropriate day to operate the baby with congenital diaphragmatic hernia?
When is the appropriate day to operate?
Yeah, what is the best moment to operate those babies?
Okay. I hope there are no surgeons in the audience here, and most of the audience are neonatologists. So diaphragmatic hernia is one condition where the surgeon is the least important person. It's the neonatologist who manages the show here. So when the pulmonary arterial pressure is down and the oxygen requirement is down, that's the time to operate on a baby with diaphragmatic hernia. There is no fixed date when you do it. It depends a lot on pulmonary hypertension. You, as the neonatologist, determine when the surgery should be done. And if the baby is doing well, if the baby is down to like 30% O2 and doesn't have significant pulmonary hypertension, the operation can be done on day 1. On the other hand, if the baby is not doing well, then it's better to delay the operation until the baby is better, because diaphragmatic hernia is a surgical condition, which is a medical emergency, not a surgical emergency. This is where you are important, not the surgeon.
Okay, thank you. Another question is, what is the best moment to use nebulized prostacyclin in patients with pulmonary hypertension?
That's a great question. There are 2 medications that you can use by the nebulized route. One is prostacyclin or Flolan, which is PGI2. You can also use PGE1 that they use to maintain the ductal patency. You can use that medication by a nebulization as well. So I tend to use these medications if you have tried inhaled nitric oxide, IV sildenafil or IV milrinone, and the baby is still not getting better. In those instances, if the systemic blood pressure is okay, it's worthwhile trying using nebulized prostacyclins. One other drug that's fairly helpful here is bosentan. So you can, if the baby's surgery is done and you're able to give some feeds to the baby, some of these babies respond well to bosentan also, oral bosentan through the orogastric tube.
Okay, thank you. Another question is better to guide the amount of oxygen with cerebral nears or instead of preductal oximetry?
That's a great question as well. So I do use NIRS monitoring of the cerebral oxygenation while managing babies with diaphragmatic hernia, but it's helpful when you're trying to wean oxygen down. Because if your cerebral oxygenation is going down on the NIRS, I tend not to wean the FiO2 too much. So my first guide is always preductal oxygen, and then second guide is NIRS. So I use both of those while adjusting oxygen in these babies.
Okay, thanks so much. Another question is, what is the best vasopressor when we have hypotension secondary to milrinone?
With milrinone, I tend to reduce the dose of milrinone first, not to use a loading dose, and reduce the dose of milrinone to 0.25 mics per kg per minute. And if there is still hypotension after that, I use vasopressin.
Okay, good. If we can use the honeymoon period to do the surgery, or it's different?
Yes, you can use the honeymoon period to do the surgery, but the honeymoon period is fairly short. And unless, like any other honeymoon after marriage, it's fairly short. So you tend to miss it often, but there are some centers. There is a surgeon in Florida who prefers to do surgeries during honeymoon period and reports good results. So if you can catch the honeymoon period, you can do surgery at that time. The problem with honeymoon is that you do not know when it will end. So it may end really fast, it may last for many days. So you do not know how long your honeymoon period ends. So that's the problem in babies with diaphragmatic hernia.
Yeah, right. What is the best approach about liquids in the first days of these patients?
So I tend to maintain around 60 ml per kg of IV fluids in these patients and slowly go up to around 80 or 100. I don't use a lot of fluids because many patients with diaphragmatic hernia tend to get fluid boluses, either in the form of blood products or normal saline or Ringer's lactate. So I tend to keep the fluid volume around 60 ml per kg for the first day.
Okay. What do you think about the early use of nitric oxide in congenital diaphragmatic hernia?
If the left ventricular function is normal and if the baby has evidence of pulmonary hypertension, I'm okay with using early nitric oxide. But most often that's not the case. And so I land up using milrinone first and then improving the function of the ventricle and then using inhaled nitric oxide in most instances.
Right, excellent. And what is your opinion about the ongoing prenatal treatments in congenital diaphragmatic hernia, like intra-amniotic sildenafil or stem cells?
The intra-amniotic sildenafil is not being used a lot. As many of you are aware, there was a separate trial of antenatal sildenafil in babies who are IUGR or growth restricted. And that resulted in more pulmonary hypertension in babies. So we are not using sildenafil anymore. The second question is regarding the use of stem cells. That's still in experimental phases. People are doing animal studies to evaluate the effect of stem cells in diaphragmatic hernia. So it's still experimental and it's not being done in clinical trials yet.
Okay, thank you. Does experimental liquid ventilation could be better than other types of ventilation or only experimentally?
Right now, there is, I did some studies with liquid ventilation more than 20 years ago, and it works quite well. But unfortunately, liquid ventilation is not available in the US right now. So there are no trials going on liquid ventilation in diaphragmatic hernia. There are some animal studies being done, but no clinical studies.
Okay, doctor, thank you so much. There are no more comments or questions. Thank you so much to be here with us and sharing your valuable knowledge.
Well, this was very enjoyable. I want to thank Dr. Nuria and Dr. Dylan, both of you, Dr. Fatima for inviting me here. This was a phenomenal experience with active participation from all of you. Thank you so much and have a wonderful Saturday. Bye.
Wonderful Saturday, yeah. Agradezco a todos su asistencia y participación en esta sesión. En nombre de la Federación Nacional de Neonatología de México y el doctor Moisés Quiles, presidente de la Federación, damos por finalizada esta sesión. Muchas gracias.